Hello, welcome to the channel. Before we start, please do me a favor, hit that like button, hit the subscribe button if you're not subscribed to the channel, hit the bell notification to stay current with my latest videos, and also to help this information reach other patients that may be looking for help. You can also find me on social media, Instagram. So today we're gonna show you and discuss about a typical case caused by BPH and how we manage it with a non-surgical, elegant fashion called PAE. We have talked in detail. If you're a subscriber to the channel, you can go back to the prior videos I posted about prostate artery embolization. Just a quick reminder for those who are new, we are interventional radiologists. We are basically radiologists by training, but also we are trained in doing very high technical advanced intervention like embolization. The concept of embolization means reducing the blood flow, and in this case we reduce the blood flow coming to the prostate, which make it shrink. So this is a typical angiography suite, and this is how we operate. We operate with machine. We operate by looking at the monitor. We do not open the patient. We do not do any surgeries. We don't do big intervention. We don't need the general anesthesia. We are interventional radiologists, so everything is done on the monitor, on the screen, using tiny instruments. The major advantage of the patient is, of course, less invasiveness, less risk, rapid recovery, and less invasive, less destructive options. So for prostate embolization, like this animation shows, the concept is to get as close as possible to the prostate via the artery that brings blood to the prostate, so we can navigate into it. We inject small particles that will make the prostate shrink, which will relieve all the symptoms caused by an enlarged prostate. We can access either through the femoral artery, as this animation shows, or my personal favorite is the radial artery from the wrist. Regardless of the approach, the catheter will be navigated. We will monitor it and follow it on the monitor on the screen. We do see all this detail. We get as close as possible. We inject what we call microparticles. We do not block the prostatic artery itself. Prostatic artery remains open, which will save the function of the prostate. Since there are two arteries on each side, we have to do the procedure on both sides, the right side and the left side, because these arteries are independent to achieve the maximum effect. Once the prostate is embolized, it will shrink, relieving the obstruction and allowing the patient to urinate normally as it. So these particles come in a sort of suspension that we inject directly in the artery of the prostate. They will navigate with the bloodstream all the way down to the tissue of the prostate, and they will cause a decrease in the blood supply to the prostatic gland, specifically to that median lobe of the prostate that caused the symptom that squeezed the urethra. So the first effect, it will make it soften. The second effect, it will make the prostate shrink naturally, and this will relieve all the symptom of prostate enlargement. Very important, we do not block the artery of the prostate itself. It will remain patent, and everything will return back to normal within a month. So I'm showing today the case of this gentleman, 88 years old gentleman with a history of BPH, benign prostatic hyperplasia, with complete urinary retention, requiring the placement of an indwelling long-term Foley urinary catheter that I'm showing here on the MRI. This is the balloon, this is the Foley, this is the bladder of the patient, which is empty. Inside is the urine, and this is the prostatic gland of this patient, which is enlarged. Unfortunately, this patient had multiple other comorbidities and diseases for which he was admitted to the hospital, so he was not admitted for his prostate. The problem is, during his admission, he developed hematuria, blood in the urine, probably related to the placement of a Foley or the exchange of the Foley catheter or irritation of the gland, which unfortunately compounded his already existing problem of chronic urinary retention for 6 months. So now he's dealing with two problems in addition of his underlying disease. In these type of patients who are elderly, who are a little bit fragile and sick and have comorbidities and other diseases, they are not the best candidate for invasive urological surgeries like transurethral resection of the prostate that will need general anesthesia, and it may make him bleed even further. So this is where the type of gentle procedure like PAE, elegant, gentle, and efficient, can act decisively in this type of patient and efficiently to solve the problem one time for all. So here, not only because of the concept of PAE is to block the blood flow, so hematuria is not an issue, independent of the size of the prostate, independently of the comorbidities associated with the patient. But not only that, PAE effect goes further to treat the underlying problem itself, which is the BPH and all the associated symptoms, and in this case, the complete urinary retention. So back to our prostate here as we scroll through. It is an enlarged prostate gland, and we're going to measure it a little bit and see how much it has a little component of intravesical protrusion of the prostate of the median lobe. So this is what we're going to target on the PAE. This is our target, this median lobe, the protrusion of the prostate. The artery of the prostate usually has two branches, one that goes into the medial lobe, one that stays in the periphery. We're not really interested in the peripheral one. We only try to target the central one, the one that gives problems, because the peripheral one has more, it's not relevant for what we do. And second, it has more chance to communicate with other organs such as the rectum or the bladder, etc. So this is the measurement. You can see it's an enlarged prostatic gland. If we look at her in the axial image, the prostate is quite large. It protrudes on top in the bladder. It is centered by the Foley catheter. The volume was calculated approximately to be approximately 75 or 80 grams or 80 milliliters. So again, a quick note here, just the most accurate way to measure the prostate is by imaging. We use either software called segmentation software, or like here we use just an ellipsoid formula, as opposed to urologist uses only his finger through the rectum, which grossly underestimate always the volume of the prostate. Okay, so what I'm showing here is a ultrasound evaluation of the patient wrist to visualize the radial artery. So this is the radial artery that we're going to use to access and do the prostatic intervention. The shadow here is the bone of the wrist. So we look at it, it kind of dives as we travel inside the muscle of the forearm all the way. We're going up until we reach the brachial artery. So we do this evaluation. It takes us 10 seconds to study the radial artery with an ultrasound just before the procedure, to make sure that the diameter of the radial artery is suitable, to make sure that the artery is patent, to make sure that there are no anatomic variants like a radial loop here that allow us to safely access the patient vasculature. Also, you can see it's very extremely superficial, the radial artery. It's literally at a few millimeters from the skin. You can palpate it with your finger. It is traveling above a bone, so it is very easy to obtain hemostasis, meaning compression, and stop the bleeding at the end of the procedure. All we have to do is put a wristband on the patient. So the risk benefit for the patient is favorable, and also majority of patients prefer the radial access. My patient asked me which is better, is it radial versus femoral. Patient satisfaction and patient satisfaction survey clearly indicate that most patients are in favor for the radial access, especially those who have undergone both procedures. Once the access obtained in the radial artery through a tiny little needle under local anesthesia, it literally takes us about 30 seconds to be within the pelvic vasculature, and it does not really matter. It's not a long way. We have longer catheter that can reach. We literally circulate with the blood and using really tiny instruments. And you can see here we are introducing what we call a vascular sheet that will allow us to perform a safe access and intervene on the patient prostate safely throughout all the procedure. Once the guide wires and the little instruments are introduced, they are navigated under fluoroscopy into the patient's blood vessels, and we do not cross the heart. We just go through these vessels all the way down to the prostate. Okay, here we see a live case for this patient, and I'm gonna comment the images as we scroll through and explain a little bit where we are and what we're doing. So this is a looped image of the pelvic vasculature. We are already in the internal iliac vasculature of the pelvis. This is the patient hip area. The prostate should be around here. The bladder should be around here. Of course, we don't see it with the x-ray. We don't see solid organs. We only see our catheter coming into the vessels and injecting the contrast, the dye that allow us to see the vessel. So we can reach extremely rapidly the internal iliac vasculature. It takes us literally 30 seconds from the patient wrist to be there. So once we are there, what we're going to do is obtain a map of his vessels, which we have done now. So this is the map of angiography map of the vessel that delineate the patient's anatomy and vasculature, and it shows us a multitude of tiny small vessels that are challenging, especially in this patient who's an older gentleman with atherosclerosis and vascular disease due to the formation of plaques inside his vessels. So this is one of the limitation of PA, and I think the only limitation in my humble opinion is the patient's own vessels. We need arteries to perform PA. If the patient's own vessels are occluded due to plaques because he's a smoker, he has atherosclerosis, etc., this is what limits us. Other than that, I think the PA can be performed in a wide range of patients. So this is the first challenge of PAE, and this is why it's considered one of the most challenging, because it has a what I call the cognitive challenge. The challenge meaning to recognize which artery is which, because everything could potentially be a landmine. You need to only recognize there's only one good artery, and we have no right to super selectively go into the wrong one, because that may cause the patient damage. So it's a cognitive challenge. The second step is what I call the technical challenge. After you recognize the artery, how are you going to get into it? So this is what we've done. I mean, it doesn't take us long. So we already suspected the location of this artery, and as I'm moving forward, we get like a more precise angiographies, more selective angiographies. And here, this is the microcatheter. This was advanced in our target suspected vessel. So now we have only a few candidates, so we're going to go a little bit more selective and penetrate those vessels. We use advanced imaging, we use mapping, we use microcatheterization techniques to get there. And then here we get super selective in a tiny small vessel. This is a subtracted imaging, so we don't see the background, but if I show you here, this is the Foley catheter. This is this tube that goes in the patient's bladder, and because the patient is in urinary retention, just to give you a little bit of landmark. So this should be the prostate at this level. Again, we repeat multiple runoff. This is called, this type of imaging where you see the shadow or image of the prostatic artery is called a in mapping or image overlay that allow us to guide us during the procedure. Again, as we move forward, we are studying more and more these vessels, getting more selective, and this is the tip of the microcatheter as we do the runoff. And then this is an older gentleman who is having troubles and issues staying still on the table. So finally, we got extremely selective in the prostatic artery gland, and these are the typical appearance of the vessels that feed the median lobe of the prostate. So this is the Foley catheter, this is the hip bone, so this is the groin, the left groin area. Our microcatheter comes down And inside his tiny prostatic artery, the prostate is super selective in the branch that goes to the median lobe of the prostate. So imagine this is the median lobe. The bladder should be somewhere around here, and these tiny blood vessels feed the prostatic tissue. This is where we're going to inject our particles. The particles will travel down these vessels, and they're going to get embedded just before the tissue of the prostate. So this will cause ischemia, meaning lack of oxygen, lack of blood. It will cause that part of the tissue to die off and to kind of shrink. It's not going to die. It's not all the tissues, not the prostate is not going to gangrene or die. So the prostate will will survive that. Why? Because there's always what we call an anastomotic circle, meaning a lot of arteries surrounding the artery of the medial lobe that are gonna take control of bringing blood back to the prostate. So you see this artery here coming on the side. This is not a artery I'm interested in embolizing because it goes mainly to the periphery of the prostate. If you look on above, another artery that may go to the bladder. So that's why it's important to do this type of procedure with a physician who's expert, who have done this procedure, because if God forbid they make a mistake and then they embolize these tiny vessels, that may lead to a problem with the bladder. Again, when cases are a little bit equivocal, or if you have a doubt, there's always the possibility of performing what we call rotational cone beam CT. In this case, we just did it. We didn't have a doubt, but we just did it to obtain better view and confirmation. And here we see a sagittal reconstruction, meaning we're looking at it from the side. You can see the Foley catheter going through the prostatic lobe, the left lobe, and the white is the dye, the contrast that we inject, confirming that we are in the area that we want. Here we're looking at it from the front, exactly as what we were looking at the angiography, and you can see the enhancement of only one half. It's perfect delineation. Every artery goes to one lobe of the prostate. We are coming from here. This is our microcatheter. If you can follow it on the 3D, this is the microcatheter. I'm going to try to follow it to show you where it goes and what it's going to end up. So we are super selective, super close to the the prostate gland. This is the contrast in the bladder. The bladder is empty because the patient has a balloon, has a Foley. This is the balloon of the Foley, or the urinary catheter. This patient is in chronic urinary retention. And here you can see the dark area, the dark side of the moon is the other side of the prostate, because we are not working on it yet. We're going to do it soon after we finish embolizing. So this is the procedure. This is the prostatic artery embolization. We basically travel to the patient own natural pathways, just like in a science fiction movie, and we use miniaturized material, almost microscopic, to perform an intervention that is well tolerated by this gentleman who has quite advanced age. He's 87, but that's not the problem. I have treated the in-shape 87 years old. This patient had multiple other diseases and comorbidities, making him very fragile, very sick, unable. He was in the hospital for something else, and then he started to have a problem of bleeding, which compounded his other urinary problem of chronic urinary retention. And he was, due to the fact that he was sick and he had all these risk factors that are making him unfit for surgery, he was referred for interventional radiology procedure to perform this, I think, an amazing procedure that helped him. Here we are looking at an axial view, meaning we are kind of slicing the prostate and you're looking at it from the top. As you can see here, one lobe of the prostate, and this is the Foley catheter in the middle. We injected the particles and we did the other side. We went to do the other side. It was actually more difficult. I'm just gonna skip it for now. And the patient had a very good recovery. A few days later, we were able to actually remove his urinary catheter, and he was able to urinate naturally and void naturally without the need for a Foley, whereas before he was in a total urinary obstruction for 5 months. As far as his bleeding and what we call hematuria, which is the blood in the urine, that blood actually stopped at the end of the procedure. So this is really a highly efficient procedure that can be done not only in older people, but can be done, of course, in any age person. Can help in one session, help with the bleeding, but also with the urinary retention, especially in a patient whose advanced age comorbidities precluded any invasive urological surgery. Again, thank you for your attention, and I hope that this was informative.